Thank you so much for having me here today. And again, I apologize. I have to give a talk at Parnassus at 11, so let's hope the bridge is on my side. I'm going to talk about something that will hopefully motivate but possibly terrify everyone appropriately, and that is homelessness among older adults and emerging crisis. I'm old, and I'm tired, and I got my disability. I can't do it no more, says one of the 350 participants in our study of older adults, 50 and older, who are experiencing homelessness in Oakland. The homeless population, as you might know, is aging. We did a study that showed in the early 90s, 11% of people experiencing homelessness, and these are single homeless adults, not homeless adults and families or homeless youth, but 11% of the single adults were 50 and older in the early 1990s. When we finished the study in about 2003, 37% were over 50. We now know that this is a generational effect. Americans born in the second half of the baby boom have had an elevated risk of homelessness throughout their lifetime, such that now it's estimated that 30 to 40% of single adults experiencing homelessness were born in that 10-year period, and probably an additional 10 to 20% were born earlier, such that it's estimated that half of single homeless adults are now 50 and older. Will the trend continue? Well, we know that there is a severe housing affordability crisis for everyone in this country, but we also know that it affects disproportionately people who are 50 and older. And so we unfortunately expect the median age of people experiencing homelessness to grow. And as this large population reaches older and older ages, we expect there to be even more homelessness among this population. So what are the implications of the aging of the homeless population? One, we're going to talk about briefly that this population has distinct pathways to homelessness that may be different than what the sort of prevailing narratives are. We know that even by the time of 50, this population has extremely high prevalence of both chronic and life-limiting illnesses, which is a change from when the homeless population were older and healthcare providers were concerned about things like infectious disease or violence, but not grappling with how you manage congestive heart failure or cancer diagnoses with people living on the street. We know that there's a high prevalence of what we call functional and cognitive impairment, things like the ability to walk, the ability to get dressed, and the ability to follow complicated series or sequential demands. Substance use and mental health problems are prevalent in this population, although less prevalent than they are among younger adults, but they really may require adjustments to the way that we treat them, because older adults with executive function and cognitive problems may not respond as well to things like cognitive behavior therapy, or programs that require the ability to walk up and down stairs and to do physical labor are not appropriate for someone who has difficulty walking. And finally, there are multiple implications because of this for housing design, and service delivery. Our study is funded by the National Institute on Aging. We enrolled 350 participants between July of 2013 and June of 2014. They all needed to be 50 and older, and they all needed to be homeless. They all needed to be living in Oakland. And we used various statistical methods to try to make sure that our study really represented the population that we were trying to reach. We follow our participants every 6 months, and we just heard word that we're very likely to be refunded for another 5 years, so the study will continue. The study's activities take place at St. Mary's Center, and we work with an active community advisory board, several of whose members are here, but that also includes participants from our study who help us design the questions, interpret the results, and disseminate our findings. We do regular study interviews and exams, and then we get to do deep dives and in-depth interviews with our participants on topics of interest. Because the study is continuing, we get to add questions. So if there are things that come up that people are curious about, we can sort of try to get answers to those questions. As I said, people have to be 50 and older, and they have to have met the HERTH criteria at enrollment. So, a few results. At enrollment, 2/3 of our populations were 60 and under, but 12% were 65 and older when we enrolled them in the study. Study population is predominantly men, which is true of the single adult homeless population. But a statistic I really think is important to recognize and that we speak to is that 80% of our participants were African American. About 28% of Oakland is African American. This statistic is replicated in every study of homelessness across this country, where African Americans are overrepresented by a factor of 3 to 4. And I think we need to speak it and acknowledge it and see the effects of structural racism, discrimination throughout people's lifetimes in entering the housing market, in job discrimination, in building of wealth, structural racism in the criminal justice system, structural racism in healthcare, and all of these things. This is where the rubber hits the road. This is what we see. We see our elder African American communities forced to live on the streets. If you remember one thing from this talk, remember this. We did long interviews with people about their whole life course, their childhood, their early adulthood, and about their history of homelessness throughout their lives. Among older homeless adults, 44% had never been homeless before they were at least 50. Their first episode of homelessness came after the age of 50. If you think of homelessness as a narrative where people who have had long lifetime struggles with substance use, mental health problems, and involvement in the criminal justice system, think again. This population were people who were the working poor, who lived their lives working hard without significant mental health or substance use problems, who then wound up homeless in their 50s and 60s. We found different pathways for those with early versus late onset homelessness. So we divided the sample into those who experienced homelessness before the age of 50 and after the age of 50. Remember, everyone in the study was homeless and 50 and over when we enrolled them, but some had never been homeless before their 50s. Those who had homelessness before they were 50 had more typical, what I think the public imagines people experiencing homelessness to be. Many of these individuals had very, very, very severe adverse childhood events. Their lives got derailed early on. Many then went on to have low income attainment in early adulthood, no spouse or partners, severe behavioral health conditions starting early on, likely related to these adverse childhood events that they experienced. They had high rates of traumatic brain injury, imprisonment, and very likely to have alcohol use problems. But those with late onset homelessness had a very different story. They had some childhood adversities, but not nearly as many or as severe. They generally hit their sort of markers of adulthood, and then late in life experienced 1 or 2 crises that derailed them and left them on the street. And these crises were things like loss of employment. Many of these individuals were low-skilled laborers who did not have pension plans, who did not have protection, and when they were 55, it suddenly became difficult to work 2 and 3 jobs. Many of them reported the loss of their spouse, either through death or divorce. A lot of them noted the death of their mom. So many were 55-year-old men living with mom, and when mom died, they lost the house that had been in their families for generations. And then many noticed their own personal illness that derailed their life. One of our participants said it was a lot of different things, but basically the new owners took over. This is of the apartment they had been renting. We were being evicted. My wife, she had just got out of the hospital, had the stroke, and was blind. So the daughter came up and said, "Don't fight it. Y'all can come and stay with me for a couple of months and save your money." So we said okay, and they didn't fight the eviction. After we moved out of the place, turned in the keys and everything, we went over to her house, and she said, "Y'all can't stay here." It turns out her partner did not want her elderly parents living there. And I said, "I got $9 in my pocket." I said, "At least let your mother spend the night because we don't have enough money to get a motel room." She said no, so that was the beginning. So this elderly man with his wife who had just had a stroke and was blind went to the streets, and that's where they were still many months later. While late onset homeless tends to have fewer vulnerabilities, still many had significant health challenges related to their homelessness. Another sort of myth I'd like to bust is that older homeless adults are socially isolated. We hear this all the time, but it isn't really true. Partially actually to help us follow our participants through the time of their study, we asked them at the outset to list everyone who might know where they were, who might be able to help us get in touch with them. And 80% of our participants were able to list someone who would know who they were and how to reach them. 60% of all of our participants listed a close family member. We've heard over time several things from our participants. One is that when they go to the hospital doesn't call their family because they don't assume that they have any and they don't bother to ask. The other thing is that many of our participants spend time staying with their family, sometimes for weeks on ends, but then return to the streets, and this has motivated us to look into why this is happening. Much of it is that their family is living in federally subsidized housing where they're not actually allowed to stay. Poor health, no matter how we measure it, is very common. 56 report their health as fair or poor. This is a one-item question that really gives us a really good sense of who's going to be hospitalized or die. About 11% of the general population report that their health is fair or poor. Self-reported chronic diseases are very common, and these may be underreported because many of our participants don't have great access to healthcare and therefore aren't diagnosed. But you can just see how many people have chronic conditions, and imagine how difficult it is to manage your diabetes and your congestive heart failure when you're sleeping outside. A very high proportion have what we call functional impairments. So about 40% had a limitation in one's activity of daily living, dressing, bathing, toileting, transferring, things like that. And you can see the vast majority of them had 2 or more impairments, which itself is a strong risk factor for needing nursing home care. And when we look at independent activities of daily living, things like being able to take public transportation by yourself, being able to locate and call a lawyer, being able to make a doctor's appointment, about half had impairments. We did neuropsychological testing and found an extremely high prevalence of cognitive impairment. So about a quarter had global impairment, meaning general impairment that affects all aspects of memory, decision-making, and things. And 35% had significant impairments in executive function, which is the ability to follow multiple sequential commands. Things like, well, first you need to go to the Social Security office and get your identity card, pick that up, and go here between 3 and 5, take these 2 buses. These things are really difficult for anyone to do, but someone with significant impairment in executive function, they're not being obstinate when they don't do that. That is really something that is outside their cognitive abilities without significant supports. We found a very high prevalence of all geriatric conditions. When we think of older adults, in some ways we're less worried about whether you have congestive heart failure and whether you have diabetes, and more about how globally you're functioning. Things like mobility impairment, over a quarter had. 34% had fallen 1 or more times in the past 6 months, leading to, as we found, many, many broken bones, broken hips, need for supportive services. 45% had visual impairment, 36% had hearing impairment, and this is after we disqualified individuals who were profoundly deaf. 4 individuals tried to be in our study who we couldn't keep in the study because we couldn't ask them questions because they were homeless and profoundly deaf. And 48% had urinary incontinence. When you talk about someone's self-esteem or their ability to present themselves to a landlord or to go to a clinic and they have urine in their clothing, they're soiled, you can imagine how difficult that is. Our overall population of very poor functional status. So while the median age was 57, these numbers looked much more like a geriatric population in their 70s or 80s in the general population, leading me to say that among homeless adults, 50 is the new 75. So when you think about a population that's in their early 50s, don't think about, someone who is still traveling widely and doing great in their 50s. These individuals really physiologically look like people in their 70s and 80s. I'm starting to forget stuff. That day I came down here, I had lost a day. Now I write everything. I used to be an organized person. I thought that I was really down here on a Wednesday and it was a Thursday, and that kind of bothered me. Illicit drug and alcohol use are common, with 26% showing signs of an alcohol use problem and 65% reporting any illicit drug use. The prevalence of illicit drug and alcohol use problems are actually lower than samples of younger homeless adults, but much higher than age-matched adults, and dramatically higher than those of the general population in their 70s and 80s. Drugs and alcohol take a much bigger toll on your body as you age, and so we really need to be concerned about this. It's worth noting that a lot of our participants told us and demonstrated that both their mental health problems and their substance use problems worsened after they became homeless, and then when people get housed, we see them improve. One of our participants told us why they use less than they used to, because I'm more mature and I don't use drugs and my mind's not like it was. Many of the participants are self-modulating their drug and alcohol ability because they realize that they're having trouble remembering. Mental health problems are very common no matter how we measure it. Well over a third met criteria for depression and a third met criteria for post-traumatic stress disorder. About 20% had had a psychiatric hospitalization in their lifetime, and 5% had been hospitalized in the last 6 months. We found very high rates of acute healthcare utilization. So we started enrolling 6 months before the expanded ACA. For the first half of our participants were enrolled before expansion of ACA, the second half after expansion, although many of them had not yet taken advantage of the ACA, but still, as a testament to the services in Alameda County, 72% were able to name a clinic outside of the emergency department where they received their care. 53% were able to give us a name of their primary care provider, which is pretty good. Half of all participants, however, had visited an emergency department in the prior 6 months that we were able to confirm. So we only counted it if we actually found the emergency department record. So this is probably an underrepresentation. We just did a chart review and found that, for instance, one of our participants had 170 visits to Highlands Emergency Department in the prior 6 months. Less than 7% of our participants accounted for half of all of the emergency departments. It doesn't take too many people who had 170 visits to sort of overwhelm everybody else. 24% noted that their visit to the emergency department was because they had worsening of a chronic illness. They knew they had congestive heart failure, couldn't breathe, and therefore went to the emergency room. 10% were hospitalized in the prior 6 months. This is actually an astronomical figure. We usually talk about hospitalizations in the past year. The only group that has 10% hospitalizations in the past year are people in their 80s and 90s, just to give you some context for that. We have very high mortality rate and high rates of institutional care. We now, because we had another death this week, have had 21 confirmed deaths since we started to enroll between 2013 to 2014. Multiple diagnoses of metastatic cancer, strokes, heart attacks, and kidney failure. Several of our participants have had to leave the study because they're under conservatorship because of severe cognitive impairment, and we have quite a few now living in skilled nursing homes. To give you some sense of housing status at 24 months, we looked 24 months after study entry, and we couldn't find 47 people. So we lost some people. So this is only of the people we could find who we think are probably more likely to be housed, because we probably are more likely to have lost people who are not housed. And at this time, 17 had died. But of those that we found, 38% were still homeless, 7% were living in an institution, and 55% were housed. Again, because I suspect that those we lost were probably more likely to be homeless, it's probably about half had found their way back to housing at 24 months. This is where they found housing. Of those who found housing, you can see of the whole population, 13% were housed at 24 months in permanent supportive housing, 6% in transitional housing, 8% in some form of subsidized housing that was not homeless specific, so things like getting a Section 8 voucher. 40% were housed on their own in free market housing, housing that they paid for and arranged on their own. Another 12% were housed with family or friends, and 2% were living in hotels with tenancy. If you look at this, you'll see of those who became housed, half became housed without any support, without any vouchers or anything, and about a third were housed in homeless-specific housing, which we defined as permanent supportive housing or transitional housing. At 24 months, approximately half were still homeless or living in institutional settings. So the homeless population is going to continue to grow, and it's going to continue to grow with older adults. This is a very high needs population that has continued behavioral health challenges and a very high prevalence of chronic diseases, life-limiting diseases, functional and cognitive deficits. Any interventions that we do will have to be fully accessible for people with mobility and sensory impairments, accessible to those who require personal care assistance. We were just having a side conversation about increased use of IHSS among people with expanded Medicaid. Many of our individuals qualify for IHSS but have not been able to take advantage of it. And we'll need to understand that older population may have important connections to other family members that need to be supported and nurtured. Housing processes and service delivery needs to be usable by individuals with significant cognitive and sensory impairments, and the fact that executive function impairments really present unique challenges that we need to take into account. We need to remind ourselves that many of the behaviors that may seem difficult to deal with may in fact be the direct result of cognitive impairment and cognitive deficits. And finally, providers need to be ready to support clients and staff through end-of-life care. This is obviously very difficult for individuals, many of whom have had different life experiences and trust issues and everything to face end-of-life care, but we also have to acknowledge how hard it is on staff who often bring individuals into programs only to find them die soon after. We need to help clients express their preferences, and we need to be cognizant of the need for palliative and hospice care outside of hospital settings and how challenging this is for marginally or poorly housed individuals. One of our Community Advisory Board members just is very thoughtful. This is a member who's a participant in the study, and told us that her partner of 14 years isn't allowed to live with me. She lives in a subsidized senior building. He is younger than I am and helps me, but he can only stay overnight 4 times a month. So he lives in a transitional shelter. So they live separate because they're not legally married and he's not allowed to be in her building. We can't risk my being evicted by breaking the rules. And another of our community advisory members, who's a homeless policy advisor, asks, how do you bring personal care aid services into a shelter setting where you may have adults who can't get in and out of the bed in the shelter or can't shower by themselves? And then does that service make it more possible for supportive housing providers to house a person who otherwise can't bathe or toilet or take care of basic needs on their own? So with that, I'm going to stop, and I think we have some time for questions. Is that working?
Is this working? Yeah,
yes.
There you go. Thank you, Margot. Another big round of applause for Margot, really. So I think that David is going to circulate and collect your questions. So if you have a question, just raise your hand with the card, and one of us will run and get it. Number of questions. Thank you.
Do you want me to just take a question while?
Yeah, maybe take a verbal question while we're waiting. Yeah.
Yes, let's.
Thank you for that presentation. I was wondering if there were any implications from the homeless folks who were able to find housing on their own that were lessons for future work.
Great question. So the question was, what are the implications of the folks who are able to find housing on their own? So one of the really interesting phenomena we found is that my study team now spends a day or two in Stockton a month. Because our study participants have found that you can find a studio apartment in Stockton for $500 a month. The other interesting thing is sometimes our study staff don't go to Stockton. Instead, they meet our participants on Sundays when they return to Oakland for church. In some ways, great news that people are able to, on their own, find housing. In the other ways, these are 55 and 6-year-olds who've spent their entire lives in Oakland, who have social support, family, and deep ties to the community, who are now forced to start over again in a distant community, and who spend a significant part of their salary to come back to their church communities on Sundays. I think that says a lot about what the true barriers to housing is. We just sort of say, well, excuse my French, but the rent is too damn high. And I think it really is incumbent on us to think about what it means that we are taking value members of our community and sending them far away from their hometowns in order to find housing. I think it also, we need to recognize the strength of some of these seniors, that they're able to navigate that on their own without cars, without the ability to drive, that they have been able to, recreate their lives. On the other hand, I'm not sure that's really a policy we want to think about. And so I think what would it mean for us if we could actually have more affordable housing in our local area, although we all know how hard that would be. Great, I'm going to...
They have a couple questions.
You have a couple questions?
Yeah, here's another question. Many qualify for IHSS, but can't get this. Why?
Why? So actually, this is the thing that I've written the new 5-year grant about, and now with the current federal election and who knows what's going to happen to the ACA, I'm pretty worried about it. As a physician, I know what meets criteria for IHHS, which is really having functional impairments is the main reason. And if you have, depending on the severity of your functional impairments, I look over our results of our participants, and 40% of them, without a doubt, it would be very easy, ethical, and the right medical thing to do to write that they meet criteria for IHHS. But many of them don't know about it. Many of them, their healthcare providers are not requesting it of them. But there are also real barriers that I'm actually talking to my friends at Justice and Aging, who's a legal group who works on senior health, to deal with it. One is the way IHHS is configured. It's very difficult to get IHHS if you don't have an address. It's very difficult to get IHHS in a shelter system, for instance, and it's very hard. They told me that there is case law in California where, ironically, they have been able to argue for IHHS for people who are on the street, but not able to for people living in congregate shelter agreements. So some of it is just the way IHHS is configured and some of the regulations around it. I think the other problem is, if you remember, IHHS depends on the client generally to appoint and manage their own care provider. For people whose family networks are diminished, or for people with poor executive function who don't have great social support, that's a very challenging relationship to manage. And I think it's incumbent on us to think about, election aside, but to think about how can we configure IHHS in a way that makes it user-friendly. I feel like in some ways IHHS is fabulous for my patients who have deep family networks, who have a daughter who's able to then take a leave from her job and be paid for the services that she's providing to mom. It's actually a lot harder to think about someone who is socially isolated and has poor executive function. So I think part of it is lack of awareness of the program, and part of it is the regulatory requirements of IHHS, and some of it is just how it's configured for people who are socially isolated.
Another question. In addition to these older adults who are already homeless, your thoughts on how to get ahead of the curve to prevent those at risk from falling into homelessness?
So I think in terms of preventing those falling into homelessness, I think there are a few things. One is there was just this remarkable study out of the Midwest where some economists realized that they had a perfect, what we call a natural experiment, where there was an organization that was giving small grants of like $500 to $800 of cash to people with crises. And that organization basically would have it until they ran out of money. So these economists realized, oh, wow, if you happen to call on Thursday the 1st, you got it. And if you called on, Friday the 15th, you didn't, just because they were out of money. And they compared the people who got these small one-time grants, average, I think, about $800, 2 years later were significantly less likely to have experienced homelessness, and it was sort of a durable and lasting. So one is to think about, sometimes people are losing their housing over being behind 1 month's rent, and once you lose your housing, it's a lot harder to get it put back, and whether there's some flexibility around that. The other thing is legal advocacy. My husband is a lawyer, and sometimes I read him some of these transcripts, and he says, oh, I could have, there's no way that was legal to evict them. And I was like, well, go tell it to the client who had no access to the legal system. So that's another thing. In New York City, for instance, is now doing an experiment where they are getting people in housing court the right to an attorney to try to prevent that. But the other thing I think for all of us to be aware of who interact with seniors is what those crisis periods are. I have to tell you that I have changed my practice, and now when I provide end-of-life care to people in their 80s and 90s, I ask them, are they worried that a member of their family will become homeless by their death? And I hear a resounding yes, and then I send them to tenants' protections and other things. And I think we need to really be aware of hospitalization as a critical risk period, partners' hospitalization as a critical risk period, and all the others. Quite many people were lost their housing because their house was sold, and so they were up to date on their rent. Their house was sold. The owner did an owner move-in, and they couldn't get back into the market. And I think we need to be cognizant of that. I'm going to ask a question that I have here, which is hunger being tracked in the study? It is. I'm just actually was up late last night working on our paper on hunger, and the rates of very low food security, which is sort of a severe sign, are astronomically high. And I would say to you that housing is hard. I get it. It's hard to build bricks and mortars housing. There is no excuse for seniors in our community to be hungry, and they are. They are actually hungry in this problem. Partly, things like food banks are not that accessible to them because they don't have storage or cooking facilities. And I think that is something we need to think about. I'm going to try to get that paper out as soon as I can, because I think it's really, when I started to see those numbers run, it was like a kick in the gut. I mean, I think people often say to me, housing is hard. We can't turn this around in a dime. We have the worst housing market in the country. All of that is true. I think the food and the hunger, we probably could solve much more easily.
Here's a question. I'm going to combine two questions. What is the role of insurers, health plans, and health centers? Great.
What is the role of insurers, health plans, and health centers? And again, I'm going to channel myself perhaps back to November 7th as I think about this. But I think there are a lot of roles. One is, I think the healthcare system interacts with individuals at high risk of homelessness and interacts with people who are homeless. The other people in my practice say to me, how is it that you have so many more people who are homeless than the rest of us do? And I say, it's just because I ask. I ask, and people don't look homeless or they don't fit your definition. And I think the first thing the healthcare system needs to do is ask. I think they need to ask about homelessness and risk of homelessness. And that's a very simple, easy thing. And I think we need to really break down those silos so that when we ask and find that out, we can quickly get people to the other services that they need. I mean, I think there's also a need for to think about things like post-acute care. We've had participants show up at our study center. Now, we are supposed to be an observational study, meaning we're not supposed to make interventions. But I would say about twice a month I get a call from my study staff saying, I know we're supposed to be observational, but you need to do something. We had someone discharged from a hospital who was an amputee who had multiple catheters, lines, everything coming in and out, who was sent out to the street. We had another participant come to us crying because she had just been discharged from an area hospital. She had a small bottle of morphine and was told she had 2 or 3 months to live. She had cancer in her liver, and she was sent to the street. I sat in my office in San Francisco and called the palliative care service at Highland, who's amazing, who said, can you hold her there for 10 minutes? And I said, we can hold her there as long as you want. She got in her car, drove from Highland, came over to our study. Our study knew that this woman had a daughter who was deeply devoted to her. The palliative care nurse at Highland called her daughter and within 2 hours had set up home hospice for her at her daughter's house. You really wonder why our hospital systems couldn't figure that out. Now, I work in a hospital. I know it's hard. I know things are busy, but we really need to do better. I think there's a desperate need for respite care. We do have some respite beds in Alameda County, which is post-hospital care for people who are homeless. They're too healthy to be in the hospital, but too sick to be in the street. We could multiply that by a factor of 10, and we wouldn't get there. We wouldn't have enough. Respite care in general, you can usually do for about $100 a night compared to hospital beds, which are $800 to $1,000 or more. The problem is there aren't easy payment systems for it. I know I set up a big center in San Francisco. I know how hard it is to get these paid for, but it would be a huge improvement if we had more respite beds.
And I think that we are kind of at the end. And I just want to say that we are going to put Dr. Kuchel's research and studies up on the conference website, and coming ones too.
And coming ones
so
too,
that
yes.
They'll be there, and we'll notify everybody that they're there.
And if anyone's here is on Twitter, I am on Twitter at mkuchel. So if you follow me, I do tweet when I have new studies coming out. That's another good way. And I have a website at the university that you can follow me on as well.
And also the questions that we didn't answer today, I'll make sure that Dr. Kuchel gets them and gives you answers. So we'll put those all up on the website. Thank you so much. So it is time for our next panel, and I'd like to ask the panelists to take the stage. And actually, I need to get my notes here. I want to introduce our moderator,